Hello and welcome. Today, we're diving deep into a complex and critical congenital heart defect, hypoplastic left heart syndrome, or HLHS. This condition affects the normal flow of blood through the heart, and understanding it is crucial for both families and medical professionals. The exact cause of HLHS remains largely unknown, but it's considered a multifactorial condition. This means it likely arises from a combination of genetic predisposition and environmental factors during fetal development. Some studies suggest a possible link to certain gene mutations or chromosomal abnormalities, but more research is needed to pinpoint specific causes. In most cases, it appears sporadically, meaning it's not directly inherited from parents, although the risk may be slightly elevated in families with a history of congenital heart defects. Now, let's explore the pathophysiology. In HLHS, the left side of the heart, including the left ventricle, mitral valve, aortic valve, and aorta, is severely underdeveloped. This drastically limits the heart's ability to pump oxygenated blood to the body. In a normal heart, oxygenated blood from the lungs enters the left atrium, flows into the left ventricle, and is then pumped out through the aorta to nourish the entire body. In HLHS, this pathway is severely compromised. Survival after birth relies on the ductus arteriosus, a temporary blood vessel connecting the pulmonary artery and the aorta, staying open to allow blood to reach the systemic circulation. However, the ductus arteriosus typically closes shortly after birth, creating a life-threatening emergency. Epidemiologically, HLHS affects approximately 1 in every 300 live births, making it a relatively rare but significant congenital heart defect. It accounts for about 2 to 3% of all congenital heart defects. There's no known significant difference in prevalence between sexes or ethnic groups. The signs and symptoms of HLHS typically become apparent shortly after birth, once the ductus arteriosus begins to close. These can include cyanosis, a bluish tint to the skin, lips, and nails due to low oxygen levels in the blood. Other symptoms include rapid or labored breathing, poor feeding, lethargy or decreased activity, a weak pulse, and cold extremities. Infants with HLHS may also exhibit signs of heart failure, such as swelling in the legs, ankles, and feet, although this is less common in the immediate newborn period. Diagnosis of HLHS often begins during prenatal ultrasound screenings, where abnormalities in the heart structure may be detected. After birth, if HLHS is suspected, a physical examination will be performed, followed by diagnostic tests. These typically include an echocardiogram, which uses sound waves to create detailed images of the heart, an electrocardiogram, or EKG, which measures the electrical activity of the heart, and a chest X-ray, to assess the size and shape of the heart and lungs. Blood gas analysis is also crucial to measure oxygen and carbon dioxide levels in the blood. While there aren't specific subtypes of HLHS classified based on anatomical variations, the severity of the underdevelopment of the left-sided structures can vary. This influences the surgical approach and overall prognosis. Some infants may have a more severely hypoplastic left ventricle than others, or the degree of aortic arch obstruction may differ. Treatment for HLHS involves a series of complex surgical procedures, typically beginning in the first few days or weeks of life. The first stage, called the Norwood procedure, involves reconstructing the aorta and creating a new source of blood flow to the body. This is followed by the Glenn shunt procedure, usually performed at around 3 to 6 months of age, which connects the superior vena cava directly to the pulmonary artery. The final stage, the Fontan procedure, is typically performed between 18 months and 3 years of age. This diverts blood from the inferior vena cava directly to the pulmonary artery, completing the separation of oxygenated and deoxygenated blood flow. In some cases, heart transplantation may be considered as an alternative option. Beyond surgery, medications are essential to manage heart failure symptoms, maintain blood pressure, and prevent blood clots. Prostaglandin E1 is often administered immediately after birth to keep the ductus arteriosus open until surgery can be performed. Careful monitoring and ongoing cardiac care are crucial throughout the child's life. Currently, there's no known way to prevent HLHS. As the exact cause remains unclear, preventive measures are limited. Genetic counseling may be considered for families with a history of congenital heart defects. Women planning pregnancy should follow general recommendations for a healthy pregnancy, including taking folic acid supplements, avoiding alcohol and tobacco, and managing any pre-existing medical conditions. The prognosis for children with HLHS has improved significantly over the past few decades, thanks to advances in surgical techniques and medical management. However, it remains a serious condition with a high risk of complications. Long-term survival rates after the Fontan procedure are improving, but these individuals often require lifelong cardiac care, including regular check-ups, medications, and potential additional surgeries. Recent research is focused on improving surgical techniques, understanding the genetic factors involved in HLHS, and developing strategies to prevent long-term complications such as heart failure, arrhythmias, and protein-losing enteropathy. Researchers are also exploring potential therapies to improve the function of the right ventricle, which becomes the main pumping chamber in children with HLHS. Ongoing research provides hope for further improvements in the outcomes for individuals born with this challenging condition. Thank you for joining us in learning more about hypoplastic left heart syndrome.